Good day to you all, dear candidates. This lecture is on the anatomy of the eyelids, and this is a part of my series on the anatomy of the ocular adnexum. Here I am going to go through the following titles. First is the surface anatomy of the eyelids, followed by the variations, and then we shall go through the structure of the eyelids, including the blood supply, nerve supply, and lymphatic drainage, and we shall end by a hint on the surgical anatomy. Now I shall start with the surface anatomy of the eyelids. And to make that easy, you have to be aware of the structure of the bones around the orbit. These bones are the frontal bone, that is giving the maxillary process of the frontal, and the frontal process of the maxillary bone, and the zygomatic bone on the lateral side, giving its frontal process of the zygomatic, and the zygomatic process of the frontal bone. If you start at the medial side to feel the margins of the orbit under the skin, you start by the lacrimal fossa, where you can feel immediately under the skin the lacrimal crest, the anterior lacrimal crest that is formed by the frontal process of the maxilla. And if you follow it through to the infraorbital margin, you may feel the infraorbital foramen 2 to 3 millimeters below the middle of the infraorbital foramen, and this is a very important anatomical landmark in introducing local anesthesia. And then next to it you may feel faintly the zygomatico-maxillary suture, that is the meeting point of the maxillary bone and the zygomatic bone. Following through to the lateral orbital margin, you may feel the suture between the frontal process of the zygomatic bone and the zygomatic process of the frontal bone at the junction of the upper 1/3 with the lower 2/3 of this lateral orbital margin. And then you may carry on to feel the supraorbital margin, which is part of the frontal bone. And this here in particular is crossed by the eyebrow, where the crossing takes place at the junction of the medial 1/3 and the lateral 2/3. That is, it is not exactly in the middle. And again, this is a very important landmark in case of eyebrow lift. And then the skin and slightly deeper to the medial superior orbital margin, you may feel the trochlea of the superior oblique tendon. Now, on examining the exterior of the eye, you can notice the medial canthal crumpled structure, which is pink in color, sometimes studded with hairs, and this is called the caruncle or the lacrimal caruncle. Next to it laterally there is a crescentic fold called the plica semilunaris, or in English the semilunar fold, which aims at pulling the tears at this area to the extent that all of us always feel the tears in abundance on the medial side of the eyelids. If you ask a layman, where do your tears come from? They would answer immediately from the medial side and point to the medial side of the eye, of course, which is not true, but they have a reason, because this area is where the tears are pulled. And then this is the conjunctiva and the junction of the limbus, that is the junction between the cornea and the sclera. Now, on everting the lower lid, and we're going to go through that later on when we describe the lid margin, the lid margin carries the lacrimal papilla, which is an elevation on the lid margin about 8 millimeters from the inner canthus laterally, and in it there is an opening which is the port to the draining lacrimal system, and it's called the lacrimal punctum. Of course, here represented by number 5, and number 6 is the posterior lid margin, which is sharp, and 4 is the palpebral conjunctiva, 3 is the fornix, 2 is the sclera, and 1 is the conjunctiva. Now, on the skin of the eyelids, there are folds. The most commonly known one of them is the superior palpebral sulcus or superior palpebral crease, which is here in pinkish line. This superior palpebral sulcus is a very important anatomical and social landmark. It gives us the appearance and lets one identify others by their position and shape. On the lower lid, there is a corresponding inferior palpebral sulcus and lateral malar sulcus and the nasojugal sulcus. The inferior palpebral sulcus is the one immediately corresponding to the superior palpebral one, and the lateral is a faint fold, and the nasojugal sulcus is a faint one that might be exaggerated in old age to give what is known as the tear trough deformity that cosmetologists and ophthalmic plastic surgeons have to deal with. Now we come to variations of the eyelids, and to start these variations, I have to tell you that this variation in shape is definitely in the two structures of the superior palpebral crease and the medial canthal fold. First, we have the variety known as the epicanthus superciliaris, where the fold starts higher at the crease and extends more below the inner canthus, and this is the commonest configuration in whites. The second variety is the epicanthus epitarsalis, and this starts at the crease and ends near and slightly below, not extending much, slightly below the inner canthus, and this is a common configuration in Asians. Third is the epicanthus palpebralis, and here the medial canthal fold is equal above and below the inner canthus, and this is a less common variety in Asians. And finally, the epicanthus inversus, which starts just above the medial canthal ligament and extends to become confluent with the lower lid fold, and this one here is frequent in infants. Here is a true live photo of the epicanthus superciliaris, which is common in whites, and this is the epitarsalis, which is common in Asians. This is the palpebralis, which is, as you can see, giving the impression of an Asian face, and it is less common actually in Asians. And finally, the inversus, which is frequent in infants. Dr. Chua in Singapore described the Asian crease as might be superciliaris, which we said is common in whites, and actually Asians call this a double lid, where the fold is there, the superior palpebral fold is there, and this is they call it a single lid. And this is the epitarsalis, less common, type 2, the palpebralis, type 3, and finally the inversus, which is least common, type 4. Now, from the exterior, we go to the structure of the eyelids, and on describing the structure of the eyelids, the following titles are going to be fulfilled. The first is the layers and lamellae of the eyelids, including the lid margin, description of the tarsus and MEIBOMIAN glands, and then we shall describe the orbital septum, the lid spaces, the lid muscles, and finally the ligaments. Starting with the layers and lamellae of the eyelids, actually the lid is composed of the following layers. First, externally is the skin, with the subcutaneous tissue, then the orbicularis oculi muscle, then the tarsus and the orbital septum, and finally the palpebral conjunctiva. The skin is of the thin type, that is, has no fat, and it's supplied with the appendages, which are the hairs, the sebaceous glands, and the sweat glands. And actually, it has the highest concentration of sebaceous glands all over the body. And then the subcutaneous tissue, orbicularis muscle, and tarsus with the orbital septum, and finally the palpebral conjunctiva. This is a sagittal section showing these structures. Externally, the skin, subcutaneous space, muscles, the orbicularis being pierced by fibers from the levator, as we shall know later on, and then the tarsus, which is the skeleton of the eyelid with the meibomian glands inside, and finally the palpebral conjunctiva, which is very strictly adherent to the tarsus. Now, these layers are arranged into two lamellae, and the lamellae is the units that we deal with during surgery. The external lamella is composed of skin and muscle, and the internal lamella is composed of tarsus and conjunctiva. The external lamella is easily separable into its two components, with a space under the skin, contrary to the layers that are forming the internal lamella, which are very adherent to one another. That is, the tarsus to the palpebral conjunctiva, and you cannot separate both. The gray line is the landmark at the lid margin, wherefrom you can enter into the space between the two surgical lamellae, the external and the internal ones. This is a colored sagittal section diagram through the eye globe and the eyelids, and you can notice that the skin and muscle are forming the external lamella, and the tarsus and conjunctiva forming the internal lamella. And here's the gray line where your scalpel can go through, separating the two lamellae, whether in the upper eyelid or in the lower eyelid. Now we come back to the lid margin. And the lid margin actually is a very important clinical area, as it is a mucocutaneous junction affected by a couple of diseases that you are going to know in your course of ophthalmic medicine. It has got a rounded anterior margin and a sharp right-angled posterior margin, and this forms the function of lid resurfacing of the cornea for its health. Structurally, it's composed of the eyelashes with their skin appendages at the outer side, followed by the gray line that I described, through which you can go into the space between the external lamella and the internal lamella, and then you find the openings of the meibomian glands, and finally the posterior sharp right-angled margin. We shouldn't forget that the lid margin contains the lacrimal puncti. Now, this is a diagrammatic presentation of the lid margin, and here is the anterior round margin carrying the eyelashes, and the eyelashes in the upper eyelid are directed upwards, forwards, and laterally, while in the lower eyelid are directed downwards, forwards, and laterally. And then you can find the openings of the meibomian glands, that is, the meibomian orifices, and finally you find the posterior sharp margin, which is like a car windscreen wiper going up and down, resurfacing the ocular surface, the cornea in particular, to keep it healthy and nice. Now here is a sagittal section showing the anterior round margin carrying the eyelashes with their known direction of upward, forward, and lateral inclination, and then the gray line that I have been speaking of, and the meibomian orifices, and finally the posterior sharp margin. On viewing the lid margin, you can see the posterior sharp margin, the gray line, the meibomian orifices, which are like white dots, and then the eyelashes with their direction, the healthy known direction, carried on the anterior rounded lid margin. This is the picture that I described in the beginning of the lecture, and here you can see number 6 is the posterior sharp margin, the white dots of the meibomian glands, the gray line, the anterior rounded border, and the lashes. Now, finishing with the margin, we come to the tarsus. What is the tarsus? The tarsus is a dense fibrous tissue plate, actually two plates, one in the upper eyelid and the second is in the lower eyelid. They are semilunar in shape with a height of 10 millimeters in the upper eyelid and 5 millimeters in the lower eyelid. Their width is approximately 29 millimeters with a thickness of 1 millimeter. They have a very important function, which is forming and supporting the eyelids in a skeletal fashion, that is, the skeleton of the eyelids. They carry inside them the tarsus glands, the tarsal glands or the meibomian glands. Now, each tarsus has a central free ciliary border at the lid margin and an attached orbital border. The free ciliary border where the lashes are, and the attached orbital border where the orbital septum attaches. And in the upper lid in particular, it is attached to the levator palpebrae superioris muscle. It has a narrow medial end attaching to the medial canthal ligament and a narrow lateral end attaching to the lateral canthal ligament. Here's the upper tarsus with its free ciliary border, the lower tarsus with its upper free ciliary border, and then the attached border to the orbital septum and the levator palpebrae superioris in the upper lid, and to the septum and the lower lid retractor in the lower lid, medially attached to the medial canthal ligament and laterally attached to the lateral canthal ligament. Now the meibomian glands. What are the meibomian glands? First, these were described by the German physician Heinrich Meibom in the 16th century, and they are actually a sort of a modified sebaceous glands, of a tubulo-racemose configuration. That is, they are acini, each having a ductule, all converging together to make a main duct, and they secrete the lipid layer of the tear film. Here is a presentation in the upper eyelid where you can see the tarsus in green with the tarsal glands inside, all converging with their ductules into a common duct that opens at the lid margin at the orifices that we've been describing. Under the microscope, the meibomian gland is composed of an acinus, and this acinus is composed of secreting cells with multiple secretory granules and the central active nucleus with multiple nucleoli, and all are connected to the ductules where you can see the secretion in white here. If we peel the eyelids from their skin and muscle, we can see the tarsi. The upper tarsus is semilunar but bigger, and the lower tarsus has the same shape but smaller. They have the tubulo-racemose tarsal glands, which are 20 to 30 in the upper eyelid, 15 to 20 in the lower eyelid. These can be seen through the transparent or rather translucent palpebral conjunctiva when we evert the eyelids. Now we come to the orbital septum, and the orbital septum is a fibrous membranous sheet which is thinner medially that extends from the orbital bony margin to the periphery attached external border of the tarsi. Here is the upper tarsus attaching to the bone through the upper septum, and this is the lower septum. Here on the sagittal section, this red structure attaching from the upper border of the upper tarsus into the orbital bone is the orbital septum. And here on the frontal view, after removing the skin and muscle, we can see the septum being pierced by the levator palpebrae superioris in the upper eyelid. It actually keeps the lids stable as the eye moves, like a sort of an anchoring of the skeleton into the fixed bone. Medially, both attached to the medial canthal ligament and the posterior lacrimal crest. And that is why if you put your finger on the lacrimal crest, you can feel the anterior lacrimal crest, which is outside of the orbit, and you cannot feel very sharply the posterior lacrimal crest. And laterally, it's attached to the lateral canthal tendon. Now, there are structures that pierce the septum. What are these? These are the lacrimal gland. And when we describe the anatomy of the lacrimal gland, you know that it is composed of two lobes, one inside the orbit that is behind the septum, and one outside the orbit that is anterior to the septum, and therefore it's going through, that is piercing the orbital septum. And then the levator palpebrae superioris tendon, then the lower retractors, the corresponding structure in the lower lid, and some vessels and nerves, which are namely the lacrimal neurovascular bundle, the supraorbital supratrochlear nerves and vessels, the infratrochlear nerves and vessels, and the medial palpebral arteries. Here they are illustrated: the lacrimal gland and the lacrimal neurovascular bundle, the levator palpebrae superioris, the lower lid retractor, the supraorbital neurovascular bundle, supratrochlear neurovascular bundle, infratrochlear and dorsal nasal artery, and the medial palpebral arteries. Here is a sagittal section of both upper and lower eyelids, and here is the tarsus and the orbital septum. And in this way you can see that this green line is completely separating what is inside the orbit from what is outside the orbit. And to make this clearer, this is a sagittal section of the bony orbit with all the structures inside together with the eyelids in the closed position. This dark red or scarlet red, or whatever you call it, I'm not good in colors as you are ladies, you call it scarlet red or burgundy red color. This is the bone, and this light green color is the tarsi, and this dark green color is the septum, upper and lower septum. As you can see, from bone to bone there is a complete sheet composed of the septum and the tarsi, separating what is inside the orbit, that is intraorbital structures, from what is outside the orbit, that is extraorbital structures. So the globe is intraorbital, but the orbicularis is extraorbital. The lacrimal gland has a part of it intraorbital and a part of it extraorbital. Then we shift to lid spaces. And what are the lid spaces? These are the potential spaces between the different layers of the eyelids. And the first one we described before is the subcutaneous space, where the terminals of the nerves are distributed, and you have the submuscular space where the vessels are running. This is very important to know during injection of any eyelid injections, in particular anesthesia. And this is the peripheral arterial arcade, and this is the marginal arterial arcade, and both are in the submuscular space. And finally, below the septum, you can find fat in the pre-aponeurotic space that is between the septum and the aponeurosis of the levator palpebrae superioris. We then come to the canthal ligaments. The canthal ligaments are two structures that anchor the medial and lateral sides of the tarsi into the bones. Here's the medial canthal or medial palpebral ligament, and here is the lateral palpebral ligament. The medial canthal ligament or the medial palpebral ligament is composed of two layers, an anterior superficial layer and a posterior or deep layer. The anterior layer attaches to the anterior lacrimal crest, and it is about 10 millimeters in length transversely and 2.5 millimeters in width vertically. The posterior layer gives off the superior and posterior limbs. We're going to see photos of this confusing structure that attach to the posterior lacrimal crest, and it is 4 millimeters in horizontal length by 3 millimeters in vertical width. And it laterally divides into the upper and lower parts that attach to the corresponding tarsus. Now the medial canthal ligament is the cord-like structure that you can feel on the medial side of your eyelids. If you stretch the skin of the eyelids laterally, you can feel it like a cord-like structure attaching to the anterior lacrimal crest. And actually it's related to a couple of structures. The superior branch of the medial palpebral artery runs behind it, and its deep posterior layer attaches to the lacrimal sac fascia, and the buccal branches of the fascial nerve pass upwards over it to reach the nose. Now, this is a diagrammatic, three-dimensional presentation of how the medial canthal ligament is structured, with an anterior limb and a deep limb or layer. The deep limb or layer is composed of the superior limb and the posterior limb, and it's attached posteriorly to the lacrimal fascia as well as to the posterior lacrimal crest. And here is the posterior part, which is attached to the lacrimal fascia around the lacrimal sac, as well as the deep fibers of the orbicularis oculi, that is the pars lacrimalis, the orbicularis oculi lacrimal portion, and all these help in creating negative pressure inside the lacrimal sac to aspirate or suck the tears from the lacus lacrimalis during the process of drainage of the tear film. Now, this cadaveric dissection shows number 6 as the medial canthal ligament and number 3 as the attachment of its medial end to the anterior lacrimal crest. Now we shift to the lateral canthal ligament. Actually, its existence is arguable. Let's say it's not an actual ligament, but rather sort of an accentuation in the interfibrillar fibers between the fibers of the orbicularis oculi, sort of condensation in the pretarsal portion. It attaches laterally to the zygomatic process of the maxilla and medially to the tarsi, and it's weaker, much weaker than the medial ligament. Here it is, condensations in the orbicularis oculi fibers, attaching to the lateral sides of both tarsi. Now we come to the extraconal fat and how the extraconal fat is distributed around the globe because of the structures of the eyelids. This is the superior rectus muscle, the inferior rectus muscle, medial and lateral recti, and the superior oblique and the inferior oblique, the 6 extraocular muscles. First of all, we have the central pad of fat, which is central around the group, together with the medial fat pad between the superior oblique, inferior oblique on one side and the medial rectus on the other side. And then the lateral fat pad, which is lateral in the orbit below the lateral rectus muscle. Now we shift to a bigger title, which is muscles of the eyelids. We start with the facial muscles, and we start with the facial muscles with the frontalis muscle. The frontalis muscle runs from the upper forehead and attaches to the eyebrow skin. Actually, it's coming from the galea aponeurotica above the skull. So it attaches to the eyebrow skin, and thus it serves in pulling the eyebrows upwards, which is an antagonistic action of the orbicularis oculi, which closes the eyelids, and it is used while looking up to further elevate the eyebrows together with the elevation of the upper eyelids caused by the levator palpebrae superioris. As you can see here, it is elevating the eyebrows. Now, the corrugator supercilii muscle, which attaches to the skin of the eyebrow, and it pulls the eyebrows towards the bridge of the nose to protect the eyes from excess sunlight. So, sort of wrinkling in the area of the glabella in between both eyes. So the corrugator supercilii is a muscle that pulls the medial ends of the eyebrows medially and down. And then we come to the procerus muscle, which arises from the lower nasal bone and attaches to the forehead skin on each side of the midline. And in this configuration and attachments, it has the function of pulling the skin into horizontal wrinkles in between both eyes. Here they are all together. The frontalis muscle, which helps to elevate the eyebrows during looking upwards. The orbicularis, as we'll describe later on, used in closure and forcible closure of the eyelids as an antagonist muscle to the levator palpebrae superioris, and the corrugator supercilii, which brings the medial ends of the eyebrows medially more, serving in the frowned, in appearance of the frown position, and the procerus, which brings the area in between both eyes into wrinkles. That is, the orbicularis oculi closure of the eyelids, levator palpebrae superioris elevation of the eyelids, frontalis elevation of the eyebrows, corrugator supercilii bringing the eyebrows down and in, and finally the procerus, which gives the frowned appearance. Here they are in cadaveric dissection. Number 4 first is the frontalis, number 3 is the orbicularis, number 7 is the procerus, and this fourth red circle here is the corrugator supercilii. Now we come to the biggest of them all, which is the orbicularis oculi muscle, and this muscle has origin in the frontal process of the maxilla and the nasal part of the frontal bone, as well as the anterior surface and borders of the medial canthal ligament. It passes a course where the fibers pass laterally, surround the circumference of the whole orbit, and spread over the temple and cheek. On doing so, it has a sort of a characterization into the orbital orbicularis, the palpebral orbicularis, and the lacrimal orbicularis. The orbital orbicularis is thicker and reddish in color, forms a complete ellipse, and blends with the frontalis and the corrugator supercilii. So it turns all around the orbit. The palpebral orbicularis is rather thinner and pale, and it arises from the medial canthal ligament from its upper border and its anterior surface, and is inserted into the lateral palpebral ligament containing the preseptal and pretarsal fibers anatomically, those in front of the orbital septum and those in front of the tarsus. And the pretarsal orbicularis is thought to have a role in the reflex spontaneous blink. Now we come to the lacrimal portion of the orbicularis, that is the lacrimal orbicularis, which is smaller thin muscle, 6 mm wide and 12 mm long, arising from the posterior lacrimal crest, passing behind the lacrimal sac to become inserted into the upper and lower tarsi, medial to the puncti, and to the lacrimal sac fascia. And as I described before, it facilitates tear pump through pulling the sac outwards, the walls of the sac, by pulling the fascia around it and creating negative pressure that sucks the tears into it. Now, to relate this structure to function, the palpebral portion of the orbicularis oculi is responsible for involuntary gentle closure of the eyelids, while the orbital portion is sharing in the firm closure as an antagonist to the levator palpebrae superioris, tightening the medial canthal ligaments. The lacrimal portion, as we said, creates vacuum, drawing the canaliculi medially, compressing them against the globe, and thus placing them to receive tears and aiding in the process of drainage of tears. Now, the muscle of Rayolin is the thin fibers at the lid margin, and these hold the lids together in a watertight fashion. Here they are, the muscles of Rayolin. This is another diagrammatic presentation where the fibers of the orbicularis are shown to have a superficial insertion of the preseptal fibers and a deep insertion of the pretarsal fibers into the tarsi. Now we shift to the levator palpebrae superioris muscle, a very important structure. It originates posteriorly in the orbit with the extraocular muscles from the inferior surface of the lesser wing of sphenoid bone just above the optic foramen. As you can see here, just above the optic foramen from the inferior surface of the lesser wing of sphenoid, and this is anterior to the common tendinous ring. Now, this structure of a muscle broadens while it passes anteriorly like a fan to become thinner and fibrous, changing into an aponeurosis. And the point of change is known as the Whitnell's ligament, which is a very important surgical landmark where the change of fibers occurs as well as the change of direction of pull. It's just like pulling a bucket full of water, heavy, out of a well. The rope has to change its direction of pull at what is called a pulley. So the Whitnell's ligament here is serving as a pulley. And it merges at this point with the septum. After that, it has to be inserted, and the insertion is into the skin of the upper lid at the crease. And actually, the fibers are the reason that the upper lid crease is formed. It's attached as well to the upper tarsus at its upper border and anterior surface for the pull to be smooth and nice in a rotatory fashion. It has a lateral horn into the Whitnell's tubercle on the bone of the frontal bone laterally, and the medial horn is attached to the posterior lacrimal crest. And the superior tarsal muscle is a very important structure, which is the deeper fibers called the molars muscle, and these are supplied by an involuntary system of the sympathetic. Here's the description of the superior tarsal muscle, a muscle of molar. It is a smooth muscle that originates from the deep fibers of the levator palpebrae superioris to become inserted into the upper tarsus and the upper conjunctival fornix, supplied by sympathetic fibers from the superior cervical ganglion coming around the arteries, and it is responsible for the tone of the eyelids. If you are awake, your eyelids are kept open by the molars muscle, and when you sleep, when the parasympathetic system takes the upper hand, your sympathetic gives less neurotic discharge, and in this way the eyelids close. So it's responsible for holding the eyelid in position in a tone, and at the same time it prevents the fornix, the upper fornix, from drooping onto the anterior of the cornea and coming through vision. Here is the structure of the molars muscle in green. It's from the deeper fibers into the conjunctival fornix and the tarsus. Here we are again to see how the levator palpebrae superior is coming from behind and piercing the orbital septum, merging with it at the Whitnell's ligament and becoming inserted into the skin, into the tarsus at its upper border and at its anterior surface, with the molars muscle attaching to the upper fornix and tarsus. Here we are again on a frontal view. You can see the orbital lobe of the lacrimal gland, the palpebral lobe of the lacrimal gland, with the marcation in between them by the lateral border of the tarsus that is merging with the aponeurosis of the levator palpebrae superioris, and you can see the lateral canthal tendon and the medial canthal tendon and the septum, upper septum, which is partially removed in this diagram, as well as the lower septum. Here's the levator piercing and inserting into the structures described before. And here's the Whitnell's ligament, which marks the the line of demarcation of change of fibers and change of direction of pull. And this is the medial horn of the levator palpebrae superioris, and this is the lateral horn. Now this is a dissection of the orbit seen from above after removing its roof, and number 9 and 10 marks the origin of the levator palpebrae superioris, but the bone is removed, and number 10 is the common tendinous ring around the foramen, the optic foramen. And this is the fan-like fleshy levator palpebrae superioris, number 4, and this is the Whitnell's ligament, the white line, a change of direction to become inserted into the various sites. And from the lateral view, again from the lower surface of the lesser wing of sphenoid anterior to the common tendinous ring, spreading anteriorly to become inserted into the eyelids, and this is its lateral side marking the line between 1 and 2, which are the palpebral lobe number 2 and orbital lobe number 1 of the lacrimal gland. Now we come to a description of the lower lid retractor. And actually the lower lid retractor is not a separate muscle, but rather a complicated structure that resembles or corresponds to the levator palpebrae superioris. The difference is that the levator can deliberately, under the will, elevate the upper lid, but the lower retractor helps to retract the lid when the eye rolls down so as not for the lower lid to come in the way of vision. It is an extension from the fibers around the inferior oblique that extend to become inserted into the lower fornix and the lower tarsus. This structure macroscopically is double layered. The anterior layer is coarse and rough, the posterior layer is dense and lustrous. The anterior layer is a continuation from the Lockwood ligament. The Lockwood ligament is condensation of Tenon's capsule under the globe that helps to suspend the globe in the orbit. Extension from the Lockwood ligament to join the lower orbital septum. Microscopically, the anterior layer is having superficial fibers of the capsulopalpebral ligament, which are amalgamated with the suborbicularis fascia and orbital septum, while the posterior layer is the deeper fibers of the capsulopalpebral fascia that contain probably smooth muscles. Now we shift to upper lid mobility, and let's check this video of closure of the eyelids affected by the palpebral orbicularis. This simple non-forcible closure is the effect of contraction of the palpebral orbicularis. Now, forcible closure is an effect of contraction of the orbital orbicularis. These are the fibers that have a complete circle around the orbit. And then this is the levator palpebrae superioris that elevates the lid without elevating the eyebrows. You see? While the frontalis here is the muscle that elevates the eyebrows. Now the capsulopalpebral ligament brings the lower lid down while looking down. You cannot bring your lower lid voluntarily, deliberately down. Now this is a photo of something interesting. This is the Millennium Bridge in a British city called Newcastle in the north, and the architect who designed it was inspired by the structure of the upper eyelid, with the upper arch forming structure simulating the lid margin, and the pathway here is simulating the tarsus. Let's see how it moves to open the seaway for ships. As you can see, just like an eyelid closing and opening with the anchoring at the lateral sides. And here are pedestrians passing through the base of the tarsus. Once again, from the lateral side, how it moves to give way for ships to pass through. Interesting how those engineers and architects are inspired by the glory mighty ability of fashioning and engineering of the human body. Now we come to the blood supply of the eyelids. The blood supply of the eyelids comes from the external carotid through the maxillary artery that gives off the zygomatic arteries and the infraorbital artery. So this is the external carotid artery giving the maxillary artery, which gives off the zygomatic and infraorbital artery. And it comes as well from the internal carotid artery via the ophthalmic artery that gives the lacrimal artery, the lateral palpebral arteries, the supraorbital artery, the supratrochlear artery, and the medial palpebral arteries. All these are freely anastomosed together to give the marginal arterial arcades at the lid margin and the peripheral arterial arcades. The blood supply here is copious and freely anastomosing. In addition, the posterior conjunctival artery that is coming from the medial palpebral artery from the ophthalmic shares in the formation of the peripheral arterial arcade. So to enumerate the arterial blood supply of the eyelids, the internal carotid artery gives off the ophthalmic, which gives the lacrimal, which gives the lateral palpebral, and with the lacrimal we have from the ophthalmic the supraorbital, supratrochlear, medial palpebral that gives off the posterior conjunctival artery, and the infraorbital artery in addition. The external carotid gives the maxillary that gives the superficial temporal artery, which gives off frontal branch, and the zygomatic arteries and the infraorbital artery. Here we are having all these branches which finally form a very free, anastomotic, copious, very generous blood supply. And in a child with thin skin, we can see here the lacrimal artery, the lateral palpebral arteries, the medial palpebral arteries, all anastomosing together to give the peripheral arch or peripheral arterial arcade and the marginal arterial arcade. Now we shift to the nerve supply of the eyelids, and the nerve supply is via an autonomic and somatic systems. The sympathetic nerve supply comes from the superior cervical ganglion, and the motor nerve supply comes from the third and the seventh. The third gives the levator palpebrae superioris, and the seventh gives the orbicularis. Now the sensory nerve supply of the eyelids is coming from the trigeminal nerve via its first branch, the ophthalmic, and second branch, the maxillary. The ophthalmic is via the lacrimal, supraorbital, supratrochlear, and infratrochlear branches, and the maxillary via the infraorbital branch. Here are the supraorbital, supratrochlear, infratrochlear, and lacrimal branches of the ophthalmic nerve, and the infraorbital branch of the maxillary nerve. Now we come to the lymphatic drainage of the eyelids. And dividing the eyelids into two halves, the lateral half is drained into the superficial parotid lymph nodes, which have another name, the preauricular lymph nodes, and the medial half is drained into the submandibular lymph nodes, and both drain into the upper deep cervical lymph nodes. Now we finally come to an interesting application, an interesting clinical application, which is the surgical anatomy. During the operation of blepharoplasty, we open the upper palpebral crease, and we can see the central fat pad and the medial fat pad. And if we are taking the subsidiary approach of lower blepharoplasty, we can see the lateral fat pad and the central fat pad as well. This is the central fat pad, in upper and lower lids. And this is the lateral fat pad, and this is the medial fat pad. In surgery for the lacrimal system, when we incise the skin and start to look for a landmark to dissect the lacrimal sac, we characterize and dissect the medial canthal ligament, the one you can see here with the probe passing under from its attaching from the medial ends of both tarsi into the anterior lacrimal crest. And this is the lacrimal sac seen here after passing a probe in the punctum and severing the medial canthal ligament from the bone to make sure this is the right lacrimal sac. During dissection for the surgery of upper lid for ptosis, the surgery called LEVATOR PALPEBRAE SUPERIORIS resection, after incising the upper crease, we can characterize and find the orbicularis, and then dissecting the orbicularis we can see the septum, and the septum has fat behind it in the retroseptal or the preaponeurotic, two names for the same space, preaponeurotic space. If we open this septum, the fat comes out, and if we retract the fat, we can see the levator aponeurosis, and this is dissecting the levator aponeurosis. And if we cut it from the tarsus, we can see the deeper fibers of molars muscle. Skin, orbicularis, septum, preaponeurotic fat, aponeurosis, and molars muscle. Here we come to the end of this lecture. Thank you very much for listening and enjoy.